Nick Jewell from London School of Hygiene and Tropical Medicine. Many of you are familiar with Professor Jewell's work as a statistician and epidemiologist. He made fundamental contributions during the beginning of the HIV pandemic and throughout. And he's made seminal contributions in the area of survival analysis and analysis of epidemiologic data. Recently, Professor Jewell has published papers in the New England Journal of Medicine and recently an editorial piece in the New York Times that you may have seen, discussing the various models that we're all trying to make sense of and how these models might be used to understand some of the dynamics of the current COVID pandemic. Nick, we're really, really pleased to have you here, and I very much appreciate you taking the time because I know your schedule must be very busy. I know there's a lot of folks here that would like to hear some of your thoughts and insights, and so without further delay, I'll turn the floor over to you.
Thank you very much.
Okay, I think we might be having some difficulty. Sorry, Nick.
Can you hear me now?
Yes, yes. That's
okay. The beginning of every Zoom talk. Can you hear me now? It's like an ad for Verizon. Thank you very much for that kind introduction, Joe. I'm really thrilled that you're hearing from Natalie Dean. So let me give a plug for your seminar. I think you said on Thursday. Is it this week or?
It's actually Friday at noon.
Friday, 2 days from now. Natalie's one of the people I listen to the most in the cacophony of opinions on Twitter and elsewhere on COVID-19. So be sure and tune in for her thoughts. I'm going to now start sharing my screen. I'm going to try and aim to stop around 9:30 because I would very much like this to be interactive, and I'm going to go quite quickly through these slides and not talk about everything on them so that we have time for questions. Let me just go to full screen. Okay. And so you all know where we are. I won't spend any time at this. As of yesterday, we're close to 5 million infections in the world and somewhat north of 300,000 deaths. We don't yet know what the ultimate attack rate will be for this particular pathogen. The attack rate in epidemiology is the fraction of the population that ultimately gets infected. You may be starting to see preliminary estimates of that in various places around the globe. Yesterday, I think there was a seroprevalence study showing 10% infection or 10% attack rate currently in the Boston area. But just to give a scale to this, it's hard to know for sure in 1918-19, the influenza pandemic, that around 1/3 of the world's population was infected with that virus before real air travel or major travel, but largely exacerbated by the First World War. About 675,000 in the US deaths. And so the deaths worldwide were somewhere between 20 and maybe even higher than 50 million. It's hard to get an accurate number on that historically. And for H1N1, which is of course in most of our memories, the influenza, swine flu influenza that came out of Mexico ultimately infected about 10 to 20,000, 10 to 20% of the world's population, but only 12,000 deaths in the USA. This was the influenza pandemic at the beginning of President Obama's term. And you've all seen these maps here. Oh, I wanted to go back. I think I'm missing a slide here. For some reason, the slides are not moving. Just bear with me a second. It's Non-responsive. Okay, I'm not going to talk about all these myths. One of the things, there's several things that have shocked me during this pandemic, despite having worked on others in the past, including SARS. But one of the things that shocked me is the lack of a definitive voice of or source for data and information about the virus. There's been an enormous explosion of scientific information about the SARS-2 coronavirus, but surprisingly, maybe a reflection of the current media world we live in and social media, about a number of myths. And here is some. One myth is that the China travel ban that the US imposed in late January saved many lives. As far as I'm aware, there's no evidence of that. It bought us time, which was might have been helpful. But it would only have been helpful if we'd acted really efficiently in that time we bought, and we didn't. It's much worse than the flu in terms of mortality and other sequelae. We're not yet even testing adequately. I'll talk about that briefly. Of course, the common opinion now is time to open up, which may be true from an economic perspective, but we're going to have to, we don't really know how to do that terribly clearly yet. And there's a lot of looking at per capita rates. That will start to become important as we move to a higher attack rate, but they're not terribly useful early on, because early on epidemics are effectively, the idea of epidemics, they're working in a very large population of susceptibles, but it doesn't really matter if that's 10 million susceptibles or 1 million when you have low attack rates early on in an epidemic. And again, I'm having trouble moving the slides. It's just not responding. Hold on a second. I'm going to stop sharing for a second and just see if I can get this to be responsive. Okay, see if restarting this has helped. Yeah, so here's the evidence that we're not doing terribly well in the US, despite that much longer period of warning than some of the earlier Asian countries. This is, as of yesterday, the total confirmed number of deaths. And you can see that Brazil is very rapidly catching up on some of the European countries that were hardest hit, and may well eventually approach the United States. So that's a real concern right now. I mentioned a little bit about testing. So this is, in the next 20 minutes, I'm just going to sweep through some ideas that I've been thinking about during this course of this pandemic. Here is the testing rates per 1,000 people. Again, this is of yesterday, and you can see that the United States here is catching up quite rapidly. This is the United States line in terms of the per capita testing rates. These are PCR tests. We're talking about tests for active virus, not yet at the levels of Italy or New Zealand, or a much smaller country, Denmark, but well beyond South Korea, which did a massive amount of testing early on, as you can see. So actually, well, everyone at the moment in the government and local and federal government tends to focus on where we are now and how well we're doing now compared to other countries, fourth in the per capita rate of testing. What's really important, of course, is not testing once the horse is bolted, it's testing when the horse is still close to the stable, and that's down here. And you can see down here that South Korea, largely because of their experience with MERS, was set up to do testing and had the personnel and the equipment to do testing early on. The United States was non-existent in testing by late March, and that was a big reason why we've seen so many deaths. This is important, of course, now as we prepare for opening up populations, but it's a different game now than it was when the epidemic first started. And actually a better way of looking at testing than per capita rates is to look at how far out into the population you're reaching with a testing strategy or testing regimen. And that's, to me, that's best reached by what fraction of tests turn out to be positive, because if that's very high, it means you're just really testing clearly symptomatic individuals where you would expect a high positive rate. If you're reaching far out into communities and testing asymptomatic people, you would expect that testing fraction to become small. What's on the graph here, which is provided by Our World in Data, is just the inverse of that test positive rate. So it's the number of COVID-19 tests that are carried out for each positive or confirmed case identified. And so you can see there, New Zealand is very high. The United States is doing very badly that way, that we're still not quite where we would want to be. We're not reaching far enough out into the community to understand where we are. I spent a lot of time early on in the epidemic at the London School talking to the modeling group there and listening, and to Imperial, which is around Imperial College, which is around the corner, about mathematical models. I put a little color-coded stoplight here about the use of models. Mathematical models of epidemics are not terribly useful to really understand what's going on at the biological level. In other words, you need to understand that before you can really construct an effective mathematical model. And many mathematical models, even when we do understand the biology, lead to similar calibration on data, even though they may have quite different projections. So it's very hard to calibrate mathematical models to know one is right or wrong. In fact, none of them are, of course, are right. So I put that in red. In orange or yellow there, you know, it's an insatiable demand to look into a model and peek forward to the future, but it's very hard to do that. It may give you a sense of the scale of what we're doing so that you can scale up mitigation and response measures. It's very hard to predict peaks, in part because human behavior and changes in response to predictions, so that it's not terribly valuable necessarily to try to be accurate with that. The green is where I think models are most interesting, which is they provide an idealized version of a world, and so we can then take that idealized version and change it a little bit and get a sense of what interventions, what their relative impact might be in an idealized world. And that might give us a clue as to the idealized version, how things will work in the actual world. Most of the mathematical models that you're seeing are a version of these compartmental models, either with stochastic or deterministic differential equations. These are deterministic here, that just capture you moving from susceptible to exposed and infectious to infected and symptomatic to recovered. You can, of course, recovered, it's really removed because you can die and be removed here. But of course, from each of these, there's a background mortality rate, particularly important in elderly populations. And these differential equations just capture the simple fact that the rate of transmission depends on how many susceptibles there are in your local population and how many infected. And you can take those transition rates and compute what we know as referred to in the popular media as the reproductive number. This is R0, means just the reproductive number before any mitigation factors or at the beginning of an epidemic, or how a virus will move in a completely unchallenged fashion. And it depends on these transition rates. And of course, it's also interpretable as the average number of infected individuals that each infected person infects during the course of their infectious period. If that's bigger than one, more infections occur and the epidemic grows. If it's less than one, the epidemic dies out. Now, the title of this talk actually came from a graph that my daughter, who works at Imperial College, Dr. Jewell, when we were talking about exponential growth and how in the early stages of an epidemic, governments and policymakers and the average person has a very hard time wrapping their heads around what exponential growth looks like and feels like, because we don't experience it, certainly not at the pace that an epidemic with a serial interval of a few days produces. And here we tried to think about mitigation strategies. So this was published in early March some point, and we were trying to persuade universities in our local institutions to go online quickly before they actually saw cases in their local community. And this simple graphic reflects that in the middle of epidemic growth, this was an epidemic growth that was doubling every 3 days, which was the way it was at the beginning of the epidemic in most countries. The idea was if one person took a mitigation step and avoided one case today versus taking exactly the same action 7 days later, it produces quite dramatically different reductions in cases, so that the caseload 30 days later is 25% the size if you take that action today rather than a week from today. That's one case averted in the early days, makes a huge difference. And that was, now of course this is old news because most places have taken a mitigation steps. This was a later graphic that Britta produced, which was looking back now and taking any model, but we picked the IHME model, which was the flavor of the day at the time we published this, probably in April sometime. And we looked at if the death rates followed the pattern that these models were using, both the known death rates and increases in death rates in the past and the projected ones in the future, what would happen if those death rates had actually been applicable a certain amount of time earlier? The exact same growth in death and then subsequent decline after a peak, but what if that had happened earlier? And you can see that even 1 day earlier makes quite a big reduction, though that's more variable state by state because of variations in death rate projections by state, but it becomes more stable with if you move things back a longer time. And 2 weeks earlier, if we had been able to impose interventions 2 weeks earlier to produce the slowing of the growth in death rates that we subsequently observed and project, we would have averted 90% of the deaths. And that, of course, got a lot of attention, and I'm happy to chat about that. Looking for, again, that's now April, now we're in May. And so now the story is, well, what about the timing of mitigation measures looking forward? Are we going too early? As most epidemiologists believe, we're being a little bit rapid in loosening some mitigation strategies. What should be the metric of what would be the metric now of saying, gee, we went too early or we went too late? It's not now the number of deaths averted or number of infections averted, because surely if we go too early and there's a recurrence, a tick up of cases, as we've sort of seen a little bit in Singapore and in Germany, and probably we'll see in some parts of the US. So the metric should probably be, and I haven't actually seen anyone publish about this yet, how long a time we buy between easing up our mitigation policies and a subsequent resurgence of infections, which is absolutely predictable. If we went back to full mixing, population mixing immediately, we would very quickly have a resurgence of infections. We're going to not do that. We're going to go back very cautiously. And the timing and the caution which we do those mitigation steps will impinge on the length of time we have to catch our breath between this first wave of infections and a any subsequent second wave or resurgence. Right now, it doesn't look like actually we're reducing the current wave that much. We're very much in a plateaued situation, but we would like to have as much time for the healthcare system to catch their breath and for us to be better prepared in monitoring a population to stamp out future waves by developing appropriate testing strategies and having available PPE supplies and so on. Okay, I talked there about the IHME model. Britta and I and a colleague at Berkeley, Joe Lunard, wrote. We're very concerned about the use of this model, and I'm perfectly comfortable saying that I think it's largely been discredited, at least the first version of this model. There's many flaws with that model. It's kind of staggering that a unpeer-reviewed, untested model of that kind should have such an impact in both states and at the federal level. I said it was untested, which is certainly true. It came out in a preprint. I don't believe the original model was ever published anywhere. But the idea behind the IHME model, it's very simple. It's just assuming that the number of infections, or in this case, actually the number of deaths, follows a Gaussian curve. And that once you see a little bit of the beginning of the Gaussian curve, we all know as statisticians that you can fill in the rest of the curve somewhat, depending on how much of the curve you're seeing. It will hit, control the accuracy, but you can do it relatively straightforwardly. And if you assume every region is following a bell-shaped curve with only maybe 2 or 3 variations, I mean, the parameters of that bell-shaped curve, its peak and its rate of growth and its the time where it starts to inflect. If you allow those parameters to vary from country to country, but otherwise every country follows a bell-shaped curve, you can start doing predictions. And that was the fundamental basis of the Institute for Health Metric Evaluation model from the University of Washington. That's called Farr's law, after the great British statistician William Farr in the 19th century. It's a 19th century technology. It was completely discredited at the time of the HIV epidemic, where it was used famously to predict that there would be about 215,000 infections worldwide by the end of the HIV epidemic. We're well beyond 50 million now, so it was not only wrong, it was wrong horribly. And there were a number of other uncertainties. I should say that on May 4th, the IHME updated their model. And instead of just using a purely statistical, empirical approach, they now started to incorporate some SER modeling. And actually, if you want to use that kind of model, I urge you to look at the one out of Laura Ansel-Meyer's group at the University of Texas, which has a better, although not perfect version. They're still struggling to capture the uncertainty in these projections. One advantage of the University of Texas is it only goes out 3 weeks. They are not trying to go out months ahead. My own view of modeling early on was to try and use local data, because we sensed that there was quite striking differences in the way these epidemics actually operate in local populations, not surprisingly. And this was, we got hold of, or were asked to look at data by the Kaiser Permanente healthcare organization in the US to look at their early data on hospitalized cases from COVID-19. And from those data on hospitalizations, we were able to back project how many infections must be going on in the community to produce the number of hospitalizations by day that we were seeing, and also study the characteristics of hospitalized patients, how long they stayed in hospital, whether they needed an intensive care unit treatment or not, which turned out to be somewhat different from the public data from China at the time. But from the back calculation of the rate of growth of hospitalizations, we were able to get an estimate of the reproductive number for infections using a fairly now well-established method from Willinga in Tunis that was developed for the SARS epidemic. And here you could see in both Northern California and Southern California and Washington State, a clear impact of the reproductive number reducing before social distancing policies were put in place. They came into place in Northern California about March 10th, so in about here, but you can see quite a clear evidence of decline before that as the population was acting on their own in response to information. And then of course it continued after formal mitigation policies were put in place, and a similar pattern in Southern California and in Washington State also. Another key thing here is this was done in early April. By the beginning of April, even though the social distancing had now been in place for 2 or 3 weeks, so much longer than the incubation period, so that people being infected now, as they are now, were being infected in a world where there was intense social distancing in place. The reproductive number was going below 1, but not much below 1, and that reflects that we have very little margin of error as we increase. I'm just going to go through these last 3 or 4 slides quite quickly. We examined that additionally by looking at the publicly available Apple mobility data. This is people consulting Apple Maps, and as a measure of mobility and therefore social distancing. And here you can see by the dates, we were able to relate the mobility data to the reproductive number. And you can see a similar pattern going on here of a fairly strong effect of the social distancing on mobility, and the relationship here, this was the reproductive number. And here in the next slide, the relationship between the reproductive number and that measure of mobility as a percent of a date pre social distancing. The one thing I would pull out from this kind of data science analysis is the quite striking differences of how reduction in mobility affects spread of the virus differently in different states. There are 4 here. New York here is in the green, and you could see in New York, which fairly dense population, a lot of public transit use and so on, it took a fairly sizable reduction in mobility before you started seeing its impact on the reproductive number. Quite different from, say, Louisiana, where even modest reductions of mobility led to important reductions in the reproductive number. And you can see that the reproductive numbers are going below 1, but not much below 1. Let's see. One final study I'll just talk about that I'm personally involved in is we just launched a week or so ago a serological and PCR survey on a random sample in Northern California to get a sense not only of the current attack rate in Northern California, not really determined to detect new infections, but really to get a longitudinal cohort established so that immunity responses for those infected can be measured longitudinally over time to see how much antibody response is waning over time. And this is a random survey, and is quite different from the terrible Santa Clara survey that came out of Stanford that you may have read about. I'm not going to talk about antibody testing. I'm just going to go to what I think the current statistical issues. They focus very much on testing strategies, which are still not well developed, and I'll just touch on that in a second. There's interest in pool testing strategies, which I've been interested in statistically for some time. A concern that PCR testing gets diluted too much by pooling, so there's real interest in developing high throughput that can handle pool testing. As I mentioned, assessing measures of immunity and the impact of relaxing mitigation policies and good surveillance strategies as we're in this entering this sort of endemic mode. Of course, interest in vaccine and treatment development, those are both really long-term. And I can answer questions about that if necessary. And the final slide here is 2 other major topics that I'd love to have conversations with. One is there's a peculiar opportunity for experimentation here because this epidemic is affecting everywhere in the world in very diverse kinds of communities, and we need to learn quickly now what makes a difference and what doesn't in terms of increasing infection, community transmission or not. There hasn't been much conversation of that. We are doing a random non-intervention study, if you will, or reverse intervention, where we're randomly allowing some researchers back on to campus as a cohort, but randomly selected a control group that isn't allowed back onto campus and testing both groups over the next 2 or 3 months to get a sense of how much difference there is in those, or how much increase in transmission. Of course, that will be impacted by the local community transmission, so it may not be generalizable, but it will at least allow us to learn at Berkeley what makes a difference. Norway was going to do a randomized return to school for K through 12, or at least grade schools, but that got abandoned by at the highest level of politics for potentially good reasons. There's clear ethical issues here, but there's enormous room for experimentation here, quasi-experimentation, and there's going to be hundreds of dissertations comparing things, but at the moment we're being very haphazard here. The big question I'm personally focusing on now is return to campus questions, and I'm sure you're talking about that at Brown and everywhere else and every other campus. Still a lot of uncertainty scientifically about the role of testing to keep campus populations safe, the frequency of how much testing. There's a fairly significant cost still at the moment, though that may decline in 2 or 3 months, but maybe not in time for the fall semester. How frequently do you clean buildings and the protocol for that? There's been very little attention of what seems to me a disastrous impact of returning to campus in the fall, which is it involves an enormous amount of travel for students all over the world. And that's, of course, an epidemiologic catastrophe in the midst of an ongoing community transmission of a pathogen, to suddenly move people around and dump them in a new place. Should you test people before they travel? What if they get infected while they're traveling? Do you test them when they arrive? That's a real challenge, and for campuses that draw on student populations geographically. I have some things I could say about the classroom size in terms of transmission of the virus and how big they should be when, in both cases, when you use social distancing, and issues about the density of using dorms and so on. I'm going to stop here. I went a little bit over, apologies for that glitch at the beginning. The one message on this slide, really, or two, is one of the reasons we've done so badly in the United States is that we've systematically disinvested in public health infrastructure. Despite warning signs of SARS and Ebola, most people in the United States, most policymakers ignored those signs, and we're sort of a hubristic feeling that those epidemics don't hit the United States. Well, now they are. And we're now paying a price. And that's a big reason for the difference between, say, South Korea and the United States, where South Korea invested very heavily in their public health infrastructure. And the mathematicians and statisticians have a real crucial role to play here. So it's not been an area of our curriculum where we've invested a lot of attention, but it's really important, and they have very important roles. It's unfortunate that many of the mathematical models being used are being used badly and misinterpreted. So to some extent, that just demands more involvement of us all in trying to get a clear and accurate message out. And I'll stop there, and appreciate you listening, and I look forward to questions.
Well, Nick, thanks very much for this rapid tour. You actually covered quite a bit of ground and touched on really some of the most important issues we're all thinking about. I think that so logistically, we've gotten one question posted, but I think that given that we have over 40 people online, it would be good, I think, if you could use the hand raising function. I could be happy to call on you for questions. And as you're formulating your questions, Nick, I wanted to just start with one kind of global question. You alluded to the fact that these models that we see are not necessarily good for like these, or maybe not optimal for real-time decision making, although they're extremely informative in helping us understand the effects of different types of interventions and that sort of thing. But one question I want to ask you is, what sort of metrics should we be looking at as we're sort of making decisions? So for example, state governments are trying to decide like which sector of the economy should I open, and how do I know how things are going, and when should I change course?
Right. Yeah, that's a great question. And of course, many of the metrics are lagged, which is part of the problem. The deaths are usually measured most accurately because we count deaths, but we've learned very quickly that deaths themselves are hard to interpret. There's reporting delay in deaths that's not usually given in publicly available death counts. The United Kingdom does give you the reporting delay, which is helpful, but that means if you use reported death counts to fit an SEIR model, it will miss the rate of growth because of that reporting delay, which will mute things. So you can get things quite wrong by even deaths. And of course, now people are focusing on all-cause mortality because there's a lag in that also, but it's also hard to interpret. Obviously, accident deaths are down, but other deaths are up because of people not seeking healthcare. But any of these metrics are quite problematic, and people are not asking enough questions about the provenance of the data and accounting for the fact. We're so desperate for information. Initially, we just ignore that it's crappy information, and we make too much of it then. And so part of the early message is one of the unfortunate roles statisticians have to play, which is just say, no, you can't say that. No, we don't know that accurately enough.
Yeah.
The metric is all.
Oh, go ahead.
Just let me say one more thing.
Sure.
Metric is very interesting to me right now in thinking about campuses. So if you're looking at a campus like Brown, what should the metric be that the president is using to determine what should we be avoiding? What should she be trying to avoid? And so some people might say, the University of California at San Diego has a model that says, let's avoid having too big an outbreak occurring before we detect it. So let's test people sufficiently often. They're talking about testing 75 to 100% of the campus population once a month. I'm not defending that or promoting it, but that's their current strategy that they're trying out now in a pilot. That is determined to give you a 90% chance of detecting an outbreak before it's got more than 10 people. And then the hope is that contact tracing suddenly allows you to clamp down on it. Well, that's a metric. I'm not going to make any comment. I could. Another metric is, I actually would like to have a testing strategy that ensures, and a contact tracing strategy that ensures my reproductive number never gets above 1. So I'm never in an exponential growth on a campus. Well, the simple models for that metric suggest you should test everyone every 3 days. And that's off by a factor of 10. And the two metrics are just different. And what the right one is for what level of infection we can tolerate in a community like a campus is really a debate that's not been answered. So it's a very interesting question. And we need to sort of decide on that quite quickly.
So it's interesting you focus on a local sector as opposed to global, like a state, for example, thinking about opening the economy might want to track PCR tests of different sectors, I guess. But you're sort of
absolutely
about local looks at different sectors seems to be
yes. Even at the state level, you've got multiple sub-epidemics happening. We all know about the nursing home catastrophe. and no models, as far as I'm aware now, are pulling the nursing home communities out from the overall community and modeling those two simultaneously, with, of course, links between, because nursing homes infections are brought in from the outside community and then they spread within. So it's like a giant household, if you will. But there hasn't been the quality of data to allow modelers to really do that effectively. But a significant fraction of the deaths are in nursing homes. So it's not, even though the population size is small, it's a sizable contributor to the overall picture, and we haven't been very effective yet in doing that.
Okay, I want to get to a couple of questions from the audience. Couple been posted online, and there's a couple of people with their hands raised. So one question from Ilana Green, in examining the effective R versus mobility, those are the plots I think you showed with the different states, has
Yes.
population density been considered?
It was considered to the extent that the mobility was measured relative to some norm for that exact population. So you're not comparing mobility data for New York with Louisiana directly, because clearly they're one's a very major city involved New York City, and one has perhaps at the state level more rural. So what was used was a measure of mobility for the same population relative to its pre-COVID-19 mobility. So to that extent, those mobility measures do account for the local nature of the population, that you would expect different mobility in different population densities, but not after that. After that was accounted, it's not done other than doing this state by state for each state separately.
Okay, thanks for that. We have another question posted from Nilanjan Chatterjee. Nilanjan, do you want to ask the question, or should I read it out? Do you have a preference? I can wait for you to unmute.
Hi, Nick.
Hi, Nilanjan.
So good to see you.
Yeah.
Yeah, so that was a really good overview. And, so I just had one question about, clearly there are risk factors which put people at differential risk for serious illness and ultimately mortality. And what is your view that this knowledge should play a role in modeling as well as policy making, in future policy making?
Well, I definitely think they should take a role in pandemic modeling. I just mentioned that for the nursing home and, of course, the elderly, where there's quite different risks, probably for infection because of comorbid conditions and certainly risks of outcome. And it's hard to do beyond the obvious one is the other one is age, of course. And so it's very easy to, in the models, to do age stratified versions of these models, with allowing for different mixing across different age groups. And that's certainly being done in the imperial model, which is an agent-based model of infection spread, a compartmental model at the individual level. So it's a simulation, basically. So that, yes, absolutely. And trying to understand the pattern of epidemic growth that we might expect, and potentially what impact and mitigation strategies might work. And you might want to target mitigation strategies. There's all this talk about isolating high-risk people from low-risk people, and therefore doing a mitigation for high-risk people that's very different from younger people. That on campuses, that's a real an issue I hear raised all the time. And these kids are 18 to 20 years old, undergraduates, 22 years old. They don't suffer as anything like it's the same impact. So why can't they all come back to campus? Well, at Berkeley, 30% of the faculty and staff are over 60. And so it's very hard to keep them separated and perform a function. And then when you ask what fraction of a population has someone with a medical condition or age or high risk status, they're living with someone like that, that 30% goes up quite dramatically. So it's quite difficult to target mitigation strategies at high risk groups. There's a very interesting issue regarding policy making. So a clear other risk factor for bad outcomes has been has been race or ethnicity, and we know that underrepresented minorities are doing far worse in suffering severe outcomes of COVID-19. That's very tricky in policymaking, because in a sense, if you have a high-risk group, you'd like to do, say, if you're doing a testing strategy, you'd like to target the tests where you think the risk is. Let's test the dorms because the risk is higher there, and not worry so much about testing students who are living at home. So if you take that in race, that's saying, oh, we're going to focus on testing African Americans, or we're going to focus on testing Latinx communities. That's very close to discrimination and bordering on targeting a certain aspect of the community in a way that caused significant issues when we try and do that with crime, where we think we can target interventions at, quote, high-risk communities where crimes are happening. So that's a really interesting behavioral and social science issue. And I'm not in favor of some factors being used to target policies rather than, I think we're all in this together is a cliche, but still an important point to make.
Okay, Nick, thank you. I know that just as a passing comment, you know, another concern, I guess it's similar to the way they target crime prevention and enforcement, is that in some communities that are most vulnerable, they're also the most vulnerable to having a positive test result, in the sense that the economic and social fallout of having a positive COVID test can be substantial, particularly now that we're talking about potentially you know, becoming more aggressive about isolation and that sort of thing. And taking a person away from their family, away from their job for 2 weeks can have really substantial consequences.
Yeah, and that's a very interesting point too. And we should make people aware that the social distancing applied in Wuhan was very different from what we think of social distancing. They were much, much more aggressive in ways that we don't feel are possible in the United States. And one of those was isolation and quarantining of even lightly symptomatic any positives basically. Yeah. And they were removed from their family, sometimes forcibly. We have not done that in the United States. In Wuhan, it was known that 70 to 80% of infections happened in the home, in households. That's probably true in the US, that obviously infections happen out there in the community, but then many of the subsequent transmissions are within people's homes. So it's, say, healthcare workers come home. But we have not done isolation of that population. And it's because it's tricky from a, you know, is it acceptable in a free democracy to do that?
Okay, thanks, Nick. We have a question from Kevin Wilson, who is here at Brown.
Sure. Dr. Jewell, thank you for taking the question. Thank you for the great talk. This is a really great overview. I've been doing a lot of work in my group with several people on the call with the state of Rhode Island on exactly these issues. So it was good to hear this overview. I had a quick question that kind of is a combination of the previous two questions, which is about the mobility data in New York. You noted that it was the amount of mobility reduction necessary to get a RT reduction was much higher than other places. But there's also been a lot of detail from New York that the hardest hit communities are less likely to have Apple phones instead of because they are relatively more impoverished. So they're more likely to have Android phones. And this kind of brings up a detail about how are you thinking about keeping track of all this kind of very local data? As an example, for instance, fare box data in New York City might be very useful, but is not widely available because there's not fare boxes. Rhode Island might have a really good flu sentinel testing system that we could bring it in. And so literally as a data management issue, how are you thinking of keeping track of all that data in order to be able to put it into these models?
Yeah, that's a very good question. And I'm not the best person to answer that. Maybe I should turn it around and ask you what you're doing for Rhode Island. And then if you have any answers, then, then me trying to answer that. But I'm a strong believer in using local information if you're trying to answer local questions. Early on, obviously, we had to rely on information from China to try and understand what was going on in the United States. And we just talked, there are many differences. So relying on what's going on in New York to say that informs what will happen in Rhode Island is problematic. Google has, by the way, has similar mobility measures. And I think maybe Rob and Ryan Tibshirani have been working on Google mobility data. So I don't want to leave the impression that there's something magic about Apple. That just happened to be in my back door. Apple is very close to here. And but there's nothing magical about it. It was just a sufficient fraction of the Bay Area population have Apple phones and use Apple Maps, but I don't actually use Apple Maps on my iPhone. I use Google Maps or Waze. So, you know, it's just at a big, wide level, you get a sufficient proxy for mobility. I don't think we know which and how many of these measures of mobility are the right ones to capture what will relate to community transmission. And I think an interesting question I'm going to throw back at you a little bit is, we saw this strong relationship between mobility and reduction in the reproductive number as mobility was decreasing. It's not clear to me that exactly the same relationship will occur as you start increasing mobility, which is the point of opening up the economy. We need to increase mobility a little bit. It's not clear that we would see the same phenomenon coming at the other end as we come out of a peak as we would see going into the peak. And so I'm a little reluctant, you know, while I believe mobility measures can be used as proxies and various other things that you've mentioned can be used as proxies to watch as we ease up and show areas of concern perhaps. It's not clear to me that relationship will be completely informed by what we saw going into the peak as we clamp down. And the world has changed too now. So people's behavior has changed. It took, in the 1918-19 epidemic, it took the United States several years for things like restaurants and so on to get back to normal. The population was sufficiently shaken by the impact of that pandemic that they didn't, even when the virus mutated to being less virulent, so the virus didn't go away, and there was no vaccine, of course, in those days, but it mutated to something that then hung around for many, many more years, but it just wasn't as fatal. But it still took many years for the US population to feel comfortable mixing the same way. It's a very interesting, if you're really interested in that, you should read some of the books on the history of the 1918-19 epidemic post-pandemic, post-1919. It took a while. And we're going to have to face those challenges too of how we use proxies to assure people that it's safe to do certain things. And I don't know that we know that yet.
So that's a really interesting point. I guess, Nick, what you're saying is that, you know, the way that we're being mobile is different post social distancing than it was pre-social distancing. So the slope of that curve, if I'm hearing you right, the slope of the curve that you showed us sort of going from, if you look backwards, going from, 70% mobility to zero, is not going to be the same as we're moving forward, because the mobility is going to come now. The added mobility is now going to come with also wearing masks, keeping distance, not going to restaurants, etc.
Correct. And just if you think of phone, mobile, using Apple Maps or Google Maps, before pre-pandemic, people were using it. I used it in London when I go on the tube and the buses to know how to get from A to B. I use it all the time because I'm, still a newcomer to London. Now, you can imagine going out to the epidemic, people may start being mobile, but they may not use the tube at all. In fact,
right.
They're discouraged to use it. They may be using their car or some other, an Uber or something to know how to get from A to B. And so the mobility may be creeping up again, but in a completely different way. I'm not now on the tube. I'm in a cab or a car to move around. So I worry a lot about that we'll be misled by assuming that as mobility that it will have the same impact of community transmission. The idea is we hope it won't, and for some of the other factors you've mentioned also.
Right. We started a couple minutes late, so I know we still have several people here. Feel free to, I don't know if people have commitments at 1, but we have, let's say, one more question from Amanda Koo.
Hi, can you hear me?
Yes, I can hear you.
Awesome. Thank you so much for the wonderful talk. I had a two-pronged question, a little bit about sort of on an individual level. Like, as we know, many states are reopening or in phase 1. And what do you think you touched upon this, but for an individual person, especially one who might not have like complete data literacy, what would be the most important things to consider when like this individual person's being asked to go back to work? So like if you were being asked to, I guess, like resume your job,
Yeah.
on an individual level, we can kind of control whether or not we want to do those types of things. What do you think is the most important thing for that person to consider?
So you're talking about the individual person to consider?
Yeah, because I think, I mean, we can
yeah.
look to policies as well, but the individual person also has their own autonomy to increase mobility or not. So
yeah, it's a great question because, you know, with all this talk of opening up colleges, and yesterday we saw, you know, the polar opposites. New York University saying they're going to fully in-person classes with great caution, but you know, with masks and social distance, but they're going fully in person. And the University of Cambridge in the United Kingdom saying they're going fully online. 2 different colleges, same day, same science, presumably, same smart people, or no, different smart people, different decisions. And so what that tells you, by the way, is these decisions are not really being driven by the science entirely. They're being driven by other factors like the financial situations are quite different in those 2 institutions. But to come back to your question, we don't really know as institutions and workplaces make those, how many people will actually want to come back, how many students will actually want to be on campus for a variety of reasons. The experience will be very different. They may want to defer, blah, blah, blah. And in an individual workplace, we've got, that's really interesting because as it becomes enforced a little bit, what should be the I think you're asking what factors should I take into account? Well, clearly your risk status is important. Not so much, we don't know a terribly great deal about individual risk factors for infection given same exposure, but we do know about outcomes. So clearly if you have existing health conditions, immune compromise, situation, age are all strong predictors of having a very negative outcome. Access to healthcare. If you have very poor access to healthcare, you've got to make a different decision from someone who has access to, you know, the best healthcare in the world. So all of those need to play a role. How do you get to your workplace? How much exposure are you going to experience? What mitigation strategies are your place of work imposing that will protect a worker? And that's a huge issue right now because there has not been a great deal of attention in the back to work focused on the debate of protecting the working people in their place of employment and as they get from their home to their place of employment. And it really has there are terrible inequities there because poorer people usually have to use more public transit. They live further away. We all know this. Because, you know, the cost of housing and so on, and they're going to be therefore exposed. And so there needs to be a real debate about protecting employees from the conditions they're going to have to work in. And so those are the questions I would be asking. I'm not sure if that's answering your question.
Yeah, that was perfect. Thank you so much. Yeah, I think that's definitely, it's difficult not to know, you know, exactly a number of tests that, you know, people would feel comfortable. And then if the workplace was testing at that rate. And I think you touched on those things, but I definitely think those are
the testing is really interesting because there's a lot of evidence that mass testing isn't terribly effective. It doesn't, unless you do it extremely frequently, which is really unfeasible, it doesn't tend to pick up. You know, you most seem to be somewhat infectious just before you show symptoms. So, you know, it's not necessarily testing. Testing is needed to detect those people, but you have to do it at such high levels, and it's not as effective probably as doing very effective contact tracing and maybe just what we would call in epidemiology symptomatic screening, you know, getting every employee to check in every day with 5 questions. Are you running a fever? Do you have any symptoms? Blah, blah. Have you got lost your sense of smell and so on? Those are pretty effective, and they're cheap and can be done at home before you head into work. So that would be another strategy I think we should be doing. But I do think a certain amount of PCR testing does create a sense of security for workers if they know that there's active surveillance going on in their institution. That it gives a more confidence that the workers are being protected.
I see.
Okay,
Thank you so much.
Nick, we're going to have to stop here. I appreciate everyone who's still with us, and thanks for the great questions. I would just remind, well, the folks that are left that we're going to redo this on Friday. And Nick, thanks very much again.
Yeah, you're welcome. And I really do encourage you to listen to Natalie. She's got some terrific ideas. So that'll
We'll be publicizing for
exciting.
sure.
Yeah, great.